So my name is Megan Carter. I'm one of the nurse practitioners in the Kentucky Children's Hospital Division of Developmental Pediatrics, and I'm going to talk today about autism spectrum disorders. My guest speaker today is Melanie Tyner-Wilson, and she'll be talking as well. And Melanie, you are a wealth of information about autism, so if you want to jump in on anything I'm saying, just please let me know. So I have no disclosures other than the fact that I work for the Kentucky Children's Hospital Division for Developmental Pediatrics. You can move on to the next slide. So the first thing I was going to do is kind of talk about the history and prevalence of autism, but given some of our time constraints, I might breeze through this really, really fast. So any of you all who are familiar with the history of autism know that in the past, it was characterized initially as a form of childhood schizophrenia, but over the years, we've kind of changed our way of thinking and what an autism spectrum disorder is. And we've kind of moved to thinking of it more as a neurodevelopmental disorder. And I put some of the dates on here just to kind of talk, familiarize you all with, through the past, we've kind of been looking for causes for autism. So in the past, we've looked at environmental causes for autism and social causes for autism. And now we're looking at biological and neurodevelopmental causes and genetic causes as well. The thing that I kind of wanted to spend more time on was kind of how the definition of an autism spectrum disorder has changed over the years. So hold on, go back one slide. There we go. So the DSM, which is the manual that mental health professionals and psychologists and medical providers that work with children with neurodevelopmental disorders use. And DSM stands for Diagnostic and Statistical Manual of Mental Disorders. It was first published in around the year 1952, and there have been several new updated versions and revisions since that time. But really, when the DSM-2 came out, autism was first characterized as a form of childhood schizophrenia in this version. And the hallmark of this was a deviation from reality. But then as we began to learn more about autism, we realized that that definition really didn't fit. So then when we moved on to the DSM-3 and the DSM-3 revision and the DSM-4, our thinking about the way that our thinking on autism really changed. We started to think about it more as a neurodevelopmental disorder that looked different in different people. So kind of in the DSM-3 and DSM-4, we started to add additional diagnoses to kind of describe the variability in the presentation of these individuals we were seeing. So we added definitions like pervasive developmental disorder not otherwise specified, Asperger's syndrome, autism. We used to have a definition called childhood disintegrative disorder that kind of describes a regression in some of your developmental and language skills a little bit later on in childhood. And then Rett syndrome used to be kind of on the, we'll call it autism spectrum, even though it wasn't on the autism spectrum. And that's a genetic disorder that's kind of associated with seizures. Okay. But then as we began to learn more about autism in the year 2013, the DSM-5 came out, and we kind of got rid of all the different diagnoses that we were using to describe people on the autism spectrum. And then we kind of began to think of autism as more of a spectrum of a disorder. So there are different individuals on the spectrum, and they all look different. And we kind of categorize them based on their level of support. And the reason that we moved to an autism spectrum disorder is because in the past, when we had all these different diagnoses like Asperger's syndrome and pervasive developmental disorder and autism, there was some confusion among medical providers and psychologists and other mental health professionals that were treating people with autism about what the difference between a person with Asperger's syndrome and pervasive developmental disorder looked like. There was some kind of confusion on, do they meet the criteria for this disorder or this disorder? And it was kind of difficult to tease those things out. And I think some of the people that helped revise the DSM-5 really thought, maybe we're missing some people with autism. And so we should probably move it to more of a spectrum instead of classifying it as a bunch of different diagnoses. So next slide. I think I've gotten ahead of myself in my notes. So I'm going to talk really briefly about the incidence of autism spectrum disorders as well, because new numbers came out this year. And this year, the CDC found that we're identifying 1 in 36 children with autism. And that number has increased over the years. If you look back at 2000, we were 1 in 150. So we think we're doing a better job about diagnosing children and adolescents and even adults with autism. I also kind of threw this little graphic on the side to kind of give you a little bit more information about some of the demographics of the kids that we're identifying. Boys are still more likely to be identified than girls, but I think we're doing a better job maybe diagnosing girls on the spectrum. Based on the newest data from the CDC, we're doing a better job about identifying children and adults from different minority populations. And then we're still finding that about 1/3 of children with autism also have an intellectual disability. So, all right. Oh, sorry. Nope, that's fine. So what I was going to talk about next is kind of, I feel like when people first learn about autism, the definition of autism itself looks really involved and can be kind of confusing. So I was going to kind of show you guys what the definition is of autism in the DSM, and then kind of go through what this could look like in a child, adolescent, or adult with autism. I'm going to give you some examples, but my examples are not going to be comprehensive because everybody with autism looks different. But I just kind of wanted to give you an idea about what certain things mean. So, so there are 5 things that you kind of have to look at when you diagnose a person with autism. The first is there's kind of a social criteria that people with autism have to meet in order to meet the diagnostic criteria for this diagnosis. So the DSM characterizes it as persistent deficits in social communication and hold on, I have to move my slideshow, and social interactions across multiple contexts as manifested by all of the following currently or by history. So this means you can have these problems currently, or you may have had a history of these issues in the past. So the first one is deficits in social emotional reciprocity, ranging from, for example, abnormal social approach and failure of normal back and forth conversation, to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. So what does this mean and what could this look like? So for social approaches, I have some kiddos with autism that are really interested in engaging with other people, but sometimes we have trouble understanding certain things like personal space. So when you first, I've had a couple of kids that I've met the first time, and they get really close to me to talk to me just because they're so excited to meet me. But they don't quite understand those aspects of personal space yet. So that's just one example. Lack of reciprocal communication or deficits in reciprocal communication. So this could mean I have some kiddos with autism that are very good at having a conversation with others, but they don't provide the background or critical information that's needed to have that reciprocal back and forth conversation. So sometimes they'll kind of jump into a topic and start talking about a certain topic, but I'm not sure what they're talking about because it may be about a past event or something that they did in the past that I wasn't there for, so I'm not sure what they're talking about. But usually if I have to talk to it, usually in the pediatric setting, there's a parent there, so I can say, can you help me get that background information that he's talking about, he or she is talking about, so that I get a little bit more information. So they're not the person that I'm evaluating for autism isn't necessarily giving me that information that I would need to understand that back and forth conversation I'm having with them. Does that make sense? So, and then in our kiddos that don't have a lot of language, sometimes we see these kiddos not respond when their name is called, or they don't really initiate conversations with other people. Reduced sharing of interest. So in the little kiddos I see, this can be difficulty sharing, not showing items of interest to others. Reduced sharing of emotions or affect could be difficulties responding to like praise from others. I have some kids that get really upset when they're praised. And some kids have difficulty kind of understanding how to respond to others in a social situation. So they get very upset sometimes when other kids are upset around them, and things like that. Lack of social initiation. I have some kiddos that I've seen in the past that sometimes only initiate interaction with others if they need help with something. And then once they get that help, there's not that reciprocal back and forth that continues with the child. Does that make sense? So, and then for number 2 is deficits in nonverbal communicative behaviors used for social interaction. So, and this can range, for example, from poorly integrated verbal and nonverbal communication to abnormalities in in eye contact and body language, or deficits in understanding and use of gestures, to difficulties in facial expressions and nonverbal communication. So what does number 2 mean? Or what could it look like? So I have some kiddos that do have difficulty making eye contact with others, or understanding or using gestures to kind of communicate with others. I have some kids that have difficulties understanding like facial expressions of others, or kind of how to use their facial expressions to help others understand kind of what's going on internally, inside their head. I have other kiddos that I see that have difficulty sometimes coordinating gestures and eye contact. So sometimes we point, but we don't necessarily look to where we're pointing. So then I have difficulty figuring out kind of what they're trying to show me or point out to me. So then number 3 is deficits or difficulties in developing, maintaining, and understanding relationships, ranging from, for example, from difficulties to adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, or to absence of interest in peers. So, what can this kind of part of the social part of autism mean or look like? Some of my the patients and kids that I've seen in the past have difficulties with what's called theory of mind. So this is difficulty kind of taking another person's perspective. And what this kind of means is this can mean like a person with autism kind of has difficulty understanding how their actions or the things they say may be construed by another individual who's kind of viewing them from the outside. Other kids with autism, have difficulties engaging in that reciprocal play. So in the little kids that I see, sometimes we get concerned when we see parallel play that continues past the age of 2, and we're not moving on to that emerging cooperative play. So parallel play is kind of when we're playing next to an individual, but we're kind of doing our own thing, but we're not doing that back and forth engaging. And then I have some kiddos that are really interested in friendship, but they have difficulties understanding some of those social conventions or social interactions. So I have some kids that they're so interested in playing with other kids that they have difficulty kind of being an advocate for themselves and speaking up. If they're in a play setting and they don't necessarily want to play a game that their peers are playing, they sometimes don't advocate for themselves and they're a little overly passive. And it's because they want to play with other kiddos, but they're not quite sure how to advocate for themselves yet. Does that make sense? So those are kind of that's the DSM criteria for the social criteria for autism. So now we're going to kind of move on to the next slide, where we're going to talk about some of the behaviors that we see that have to be present for a diagnosis of autism to fit. The next criteria is you have to have restricted and repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the following currently or by history. So you have to have 2 of these. So you can have stereotyped or repetitive movements or use of objects or speech. So this can be the stereotypical thing you think about with autism in terms of repetitive movements like hand flapping. I have some kids that use repetitive speech. The other thing that we can see sometimes is an insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. I have, some people are very, very routine oriented to the point if our routine gets deviated, it's very difficult for us to kind of continue on or transition to our next activity if that routine is disrupted. So individuals with autism can also have highly restricted fixated interests that are of abnormal intensity or focus. I have particular kids that I see sometimes that are really focused on a particular topic, like Rebel from Paw Patrol, and all we want to do is watch Paw Patrol and carry our Rebel figurine around us. But then when mom wants to turn on the news for 10 minutes or wants to kind of turn on a movie at night, the kiddo gets very upset because Paw Patrol is not on the TV anymore. And then individuals with autism can also have hyper or hyporeactivity to certain sensory input or unusual interest in sensory aspects of the environment. And what this really means is this is that sensory hyperresponsiveness. So we're sensitive to maybe loud noises and cover our ears. Sensory hyporeactivity is kind of that high pain tolerance or that we see sometimes. Or sometimes we see what we call sensory seeking behavior. We like to feel certain textures, or in little kids, we often see them put items in their mouth that are not edible items. So those are just some examples of sensory behaviors that you may see. The symptoms of autism must be present in the early developmental period. But the important thing to remember is every person with autism looks different. And just because you have autism doesn't mean that you don't have social skills. There are a lot of people out there with autism that have some really good social skills. But as you get older and you grow and develop, there are a lot more social demands on you in the school setting, in the extracurricular setting or your setting of friends that you're in. And then also in when you think about occupational skills as an adult at your job, there's a lot more social demands on you than, as an adult than when you were 2. So sometimes this can explain why individuals with autism often get diagnosed later on in life, because they've been able to kind of use the social skills that they have up to a certain point, but then sometimes the social demands get a little bit more difficult for them and they recognize that they need a little bit more help. Symptoms, they have to cause clinically significant impairment in social, occupational, or other important areas of functioning. And these disturbances are not better explained by an intellectual disability or a global developmental delay. And the important thing I want to say about this is you can have an intellectual disability or a global developmental delay with your autism diagnosis, but the symptoms that you're seeing have to be explained by autism and not the intellectual disability, if that makes sense. And sometimes that's difficult to tease out. And that's why it's really important to get a really good diagnostic evaluation from somebody who's experienced and seeing kids with autism a lot. So there are a lot of people who can see kids with autism, including developmental behavioral pediatricians, neurodevelopmental pediatricians, neurologists, psychiatrists, and psychologists. Some pediatricians in the community or primary care providers are comfortable making a diagnosis with autism, but it's going to be really important that you still get that diagnostic evaluation, because you really need to have a good and detailed developmental history to kind of, especially as a child gets older, you need to kind of prove that the symptoms kind of were present in the early developmental period. We had some difficulties. You really need to look at an individual's adaptive skills, so their life skills, how well are they able to kind of do things on their own in certain settings. And then you really need to do a good autism assessment. So there are different kinds of autism assessments that can be done. Sometimes there's a structured parent interview. And so the most common example I give of this is the Autism Diagnostic Inventory Revised, or the ADIR. If anybody in this lecture has been through the Fayette County School District for an evaluation, a lot of their psychologists like to use this to do a really long structured parent interview to get more information about the child. We have some people sometimes filling out questionnaires to ask additional information. So some of the questionnaires that are commonly used are things like the child behavior checklist, the social communication questionnaire, the social responsiveness scale. And then it's really good to have a structured observation with the child so that the clinician or whoever is, or mental health professional or psychologist, whoever is making the diagnosis, really is getting some good face-to-face time with the person they're diagnosing to see how they look clinically, and then also take into account the parents' information. So the gold standard test, and I'm going to put that in quotes right now, for diagnosing autism is the Autism Diagnostic Observation Schedule, 2nd edition. And this has specific modules that range from toddler, so it starts at 12 months, to adults. And it's based on your level of language and your age. So, and then the other tool that can sometimes be used that's very helpful, that is the Childhood Autism Rating Scale, 2nd edition. I've used this before some in my practice, and it's very helpful and a very good instrument to use outside of the ADOS as well. And then especially in children, you really need to make sure that you get good developmental testing done to look for other delays in development, and possibly the speech, fine motor, gross motor, problem solving, or social skills, to look for the other issues. In adults, it would be really important to also kind of do a really good comprehensive mental health exam to make sure that there aren't any other comorbid developmental or mental health diagnoses that may be going on, like anxiety or depression, which we commonly see in our adolescents and adults with autism. So next slide. I just kind of threw this slide in here, and I'm going to go through it very briefly. There is a difference between the medical and educational diagnoses of autism. The medical diagnosis obviously takes place in the medical setting. The educational diagnosis takes place in the school district. Sometimes if you're going to a school district and you already have your medical diagnosis of autism, sometimes the school district will consider some of the testing that's been done in the medical setting to justify the development of what's called an individualized education plan. But in the medical setting, it's kind of hard to get testing done in the school. We usually add this it's hard to get testing that's been done at school approved by the insurance, really, to diagnose autism. They want you to do your own assessment in the medical setting. So usually what we do is we get all the information that the school has done and kind of list that in our good developmental history, but then continue to do some individual assessments with the patient.
Megan, can I jump in for just a second?
Sure, Melanie.
Yeah, and thank you for doing that slide, because I think that medical versus educational, they're very different things that you get when you supports in school versus a medical diagnosis is necessary for trying to be approved for supplemental security insurance for a child, and or getting onto any of the Medicaid waivers. So they're very kind of their own unique. They're both important, but they both bring with them their own unique things that you are able to access as a result of having them. Thanks.
Thank you, Melanie. Okay, so I'm going to briefly touch on these because I see I'm kind of getting close to the 30-minute mark, and I want to leave time for Melanie to talk. So we can do medication from a medical provider perspective. You can do some medication management for things that co-occur with autism, like tics, ADHD, anxiety, aggressive behavior, and mood disorders, but I'm not going to go through that today just because that's kind of done on an individual basis. Some of the things that we kind of look at from the medical approach when we see patients with autism is one of the practice standards for our division for developmental pediatrics in general is a referral to genetics, because there are some genetic syndromes that can co-occur with a diagnosis of autism, and some examples include Fragile X syndrome, neurofibromatosis 1, Rett syndrome, tuberous sclerosis, and Timothy syndrome. And so I tell parents, we may do some testing and find out that nothing's there, but if there's something there, we wouldn't want to miss it, just in case that, we find something abnormal. We often refer some of our kids with autism or newly diagnosed children with autism to neurology. And the reason for that is people who have been diagnosed with autism are at a little bit higher risk of developing seizures. So if we see symptoms that we are concerned about might be something like seizure activity, we usually send you on to neurology for evaluation just to make sure there isn't an underlying seizure disorder present. Sometimes we send some of our kiddos with autism that I see have really restricted diets. And so they have some issues with chronic constipation. So we often send these kiddos on to GI to kind of look for any nutritional deficiencies. I've had a couple of kids that have had like celiac disease. And so they've kind of done some dietary modifications. And then a lot of times they'll work with the family to develop a really good bowel regimen to kind of clean out that constipation and make sure we get some regularity. Some of the kids that I see have pica, which is kind of eating or mouthing of non-edible items. And so usually when we see that in some of our kids, we work with the families or the primary care providers to do like a medical workup to make sure there's nothing like iron deficiency anemia that's present. A lot of my kids and adolescents that I see also have issues with sleep. So sometimes we'll do some testing, some lab results to just make sure like all our iron studies are normal if we have some restless sleep patterns. Sometimes if there's a concern that we're doing some really loud snoring at night, we'll send over a referral to ENT to make sure we don't have anything like obstructive sleep apnea going on, and we might need our tonsils and adenoids removed. And then if we continue to have sleep patterns that aren't where they kind of need to be, sometimes we'll send you on for like a sleep study to make sure everything's going okay, or we can do some medication management. Safety is a big thing with kiddos with autism. A lot of the kiddos I see with autism are at risk for elopement. They're at a higher risk of having accidents. And then some of my kids that eat non-edible items have ingested things that are kind of dangerous and have had to go to the emergency room. So it's just really important to have a good safety plan for these kids. Okay, recommended therapies. I put kind of the range of what can be involved in a kid's treatment plan for autism. We've got speech, occupational therapy, feeding therapy, physical therapy, ABA therapy, social skills, group instruction. And these therapies can take place in the outpatient or the school setting. And I put an example here of what kind of a social skills group looks like. Let me see if this will work. Could you try and click on the YouTube and see if it'll work?
This is no ordinary game of dominoes.
Oh, careful.
For these kids on the autism spectrum, it's a way to learn important social skills. For many with autism, social situations can be especially overwhelming. The UC Davis Mind Institute Social Skills Training Program gives them a comfortable place to practice having two-sided interactive conversations, recognizing emotions in others, and problem solving. Because these skills are so complex, the instructors break them down and use visual supports. The dominoes represent how our reactions to a problem impact others' reactions. Parents and instructors agree. They notice a positive change in the students. Each child has individual goals, so they can excel at their own pace, learning new skills and making friends along the way.
Okay, I think that's it.
Short is supported by UC Davis Health.
Okay, so go ahead and go 2 more slides, I think. Okay, so I briefly wanted to touch on, if you're a parent and you're trying to get a child in for an evaluation, there is a national shortage of developmental behavioral pediatricians across the United States, which is resulting in longer than normal wait times for formal identification and diagnosis. And so what I kind of wanted to briefly say is, if you're on a waiting list and you're waiting, it's really important to work with your pediatrician or primary care provider to kind of, you can get started on doing kind of some things to help your child in the meantime while you're on the waiting list. So it's really important to work with your primary care pediatrician to make sure that you're doing a standardized developmental screening tools. The recommended ages that I have are 9, 18, and 30 months. And then you can do a formal autism screening using the instrument. The MCHAT on here is the modified checklist for autism in toddlers. Primary care providers should be doing the screening at 18 and 24 months. And it's really important to get a hearing and vision screen for your child or patient. And the reason for that is, some of our kiddos do have difficulties hearing or may have some hearing loss. And we just need to make sure that a kiddo's hearing is within normal limits before we do some developmental testing. You can get started in speech and occupational therapy to kind of work on, any speech delays, or speech therapists are often good at working on some of those social skills that are involved in language and reciprocal communication. You can work with an occupational therapist to work on fine motor or life skills. And then you can go through preschool or the school district to get an evaluation, and just make sure your primary care provider or pediatrician refers you for that developmental pediatrician in your area so that you can get on the waiting list. And with that, I'm going to kind of switch over to Melanie and let you get started.
Okay, thank you, Megan. That was wonderful. I worked for several years in the developmental clinic, and there be involved with that department over the years. I have to admit, my greatest honor is being the parent of an amazing young man who just happens to be autistic or have autism. My loved one is now an adult who uses an AAC device to communicate. He has aphasia, and this impacts his verbal communication ability, and he uses echolalia, Gestalt language, to communicate his thoughts, and I'm learning more about it every day. But being his parent has just been a way to, it's just really made my life very, very complete. I'm honored to be his mom. When our family first received the medical diagnosis in 1995, there was a limited services and supports available, and every person that I encountered, whether it be a child care provider, a preschool teacher, a elementary school teacher, they all had very, very limited information or training in the area of autism. And this would have been, to relate back to Megan's slide, when the DSM-3, DSM-4 was in place, and the incidence rate, I think, was somewhere about 1 in 500 or 1 in 1,000 at the time. So we really had, I just repeatedly experienced that over and over and over again. We had the same experience with physicians and pediatricians, and as a result, my life became a lot about finding resources and services in the area of autism. And it's just, that's why it's just a real great honor to have been able to excuse me, work in the developmental pediatrics clinic, because I was able to provide caregivers all the things that I wish I would have been told a long time ago when we first got our son's diagnosis. But I love the fact that Megan has listed safety in the list of important things that need to be included. because safety is like the most important thing as a caregiver that we need to do. It's a natural thing for kids to want to explore their environment. The work of a child is play, and our job as caregivers is to provide as safe an environment as possible so that the child can learn and explore and find ways to communicate. But oftentimes they don't have the ability to let us know that they want to go outside. And so it becomes really important to provide supports. And one of the neat things that Developmental Peds does, and I think they still do, is they provide audible alarms that you can put on doors and windows and big stop signs, and to be able to have a way to have a safe environment for the child for when they learn how to unlock the deadbolt or how to climb up on a chair and open the door, open the window. So the reason why it's so important to include safety, and it is a medical concern, is if a child were to get out, oftentimes homes have ponds or water areas, or they live close to a busy street. And so in making sure that we have a safe environment for our loved ones becomes really, really important. And I say this from experience because my own son eloped from school, eloped from our home several times. And I actually got to be very good friends with the police chief and the fire chief because of that, because of him wandering away from home. So I guess learned from my 2020 hindsight. Also, what Megan's got on the slide here is about resources that are available. The Autism Society of America and the Autism Society of the Bluegrass were just natural communities for me to get involved with, because it was an opportunity to connect with other caregivers, other self-advocates that had families, loved ones like my son, and I didn't have to explain myself or explain my child. It welcomed me and accepted me into the community. And I'm now at a point in my life where I just want to figure out ways to give back. The Autism Navigator is a website that I think is really helpful, and we've shared it as a resource to families that have a new medical diagnosis, because it has small video vignettes that have information about interaction with a child that a parent can go on, and it's free, and watch it and see if it's similar or different to the interaction that they're having with their loved one. And at this point in my life, I'm very much involved with the Autism Society of the Bluegrass. We're all volunteers. We do a walk on an annual basis. We are just a bunch of motley caregivers that want to give back to people that are new to the journey of autism. And so we pride ourselves in trying to find ways to provide support to families in the community and in the state that have needs. There are also some programs that we do. We have a monthly meeting where there's a topic every month. We have an Eagles support group that is for adults and individuals with autism that are able to communicate. And we also provide resource and referrals. Also, there's Kentucky Spin, which is our state's parent training information center, and they do all kinds of webinars and podcasts and resources throughout the state and provide lots of great information. Top Soccer, that's listed on here, is also another program that is unique to the Lexington area, and it's very much focused on all disabilities, but it's a way for a child and an adult to learn skills of interacting around soccer. There's also other groups that I didn't put on this slide, and I apologize for that, but there's also ASON, Autistic Self-Advocates Network. They're a community that they're all individuals that are self-advocates of autistics themselves. And both my son and myself are members of that group. Also, there's a really neat program. It's called Aaron's Hope. That's for youth ages 12, I want to say, to 24 or so that have autism, that can communicate. And it's just a support group where they do a lot of great programs. One of the things that I've noticed over the years, and here's visual supports that can be a helpful resource for a child if they have difficulty communicating. Visual supports can, that was something that my son was not able to do in terms of talking. And so we use visual supports quite a bit, where we would have a picture of a highly desired item so that he could begin to point or touch or grab the visual to be able to provide, help us to understand this is what he wanted or he needed. It also was a way that he could also tell us, no, I don't want orange juice. I don't want milk. I want apple juice. So it was a way for him to also say, no, thanks, no, thanks. The other thing is a visual schedule can be very helpful to help a child and a family put together the sequence of events in their home, like a morning routine or an evening routine, to be able to plan their day, so that you have a visual reminder and a support for the child to follow. And it really does help, because that's something we still use, a visual routine or a schedule, a structured schedule, where my son chooses what he wants to do on a daily basis. And it helps with just being in control and also being able to know what is coming next. The things that I guess as a parent of a 30-year-old, one thing I wanted to say in closing is that with the statistics that Megan shared, the 1 in 35 or 1 in 33, that CDC reported, we are at a crisis, because as a parent and somebody in the senior season of my life, I'm trying to plan for my child's needs after I'm gone. And I worry about having adequate, safe, and affordable housing, employment opportunities, food insecurity issues, transportation, and other things that are in very limited supply in our country and in our state right now. And so I just think that there's really a strong sense of urgency to move forward with trying to make sure that these things are in place. I hope that it's not something that your family or your loved one or you yourself are dealing with right now, but it's very, very challenging in my life. That's it. I'm done.
Thank you, Melanie. Does anybody have any questions?
I think I saw a question in the chat. I wasn't able to read the entire question though.
I think I've tried to answer a few questions that were in the chat. I did also put some information. There's a support group about called Aaron's Hope for adolescents and young adults. That's been a good resource for some of my patients.
And the question about ASON is Autistic Self-Advocates Network. And the Miracle League, that's also another really great, in Lexington, there is a program called, through their Parks and Recreation program, called Therapeutic Recreation. And that has been a place where my loved one has found a community, but they have programs for all different ages to be able to participate. And the Miracle League is a program that has, I think, recreational baseball, softball activities for the young child as well as adults.